Welcome back to the Anja Health Better Birth podcast. We are super excited today to have Dr. Steve Rad with us, a maternal fetal medicine specialist, and also general high risk pregnancy specialist. So, thank you so much for being here.
Thank you very much for having me. It's a pleasure and honor to be in your podcast, which I've heard a lot about.
Oh, yeah, that's so awesome. I'm grateful that you're here, especially since I know you rushed from surgery this morning.
Yeah, I've been up actually since yesterday.
Oh my gosh.
We had an emergency surgery last night.
Oh,
So then I
wow.
just ended up and then the surgery this morning, and surgery this
Mm.
afternoon.
Okay, wow.
So I just
Awesome.
ended up not sleeping.
Okay, cool. Well, yeah, I'm super grateful that you're here. You look fresh.
Yeah, I took a shower in between.
Okay, cool. Well, yeah, as our listeners know, Anja Health does cord blood banking and also placenta stem cell banking. So I typically like to start off by just getting your general take and experience with cord blood banking. So yeah, have you collected cord blood before? And typically, how does it work when you collect it?
Yeah, absolutely. So as you said, I'm a high risk pregnancy specialist. And so I do consultations for high risk pregnancies and
Hmm.
help other obstetricians, but I also practice obstetrics. So I still do a lot of deliveries.
Cool.
And so absolutely in a lot of my deliveries we do collect cord blood, and we have been for many years.
Awesome. Cool. Do you have any tips or tricks that you do when you collect cord blood?
No, I mean, now we do delayed cord,
Yeah.
um delay cutting the cord.
Yeah.
So we just have to be kind of quick.
Mhm.
uh, if the patient is requesting the cord blood collection,
Right.
you don't have an infinite amount of time, so we have to do our delayed cord clamping. That takes priority, and then
How long do you typically do it for?
about 60 seconds,
Okay, cool.
and then and then we already have it ready to go. Basically, the cord blood collection kit, so we can do it right away
Okay,
before it's
awesome.
too late. So there's not an infinite amount of time. You have to be quick and ready,
Yeah,
prepared.
definitely. Yeah, especially since you're a high risk specialist, I'd be interested in getting your thoughts on cord blood usage immediately after birth in the case that there are complications. Like, for instance, we were chatting earlier about our partnership with Billion to One at Anja Health, and they are able to cover the first year of cord blood banking if the baby or mother has some sort of complication that they're testing for. So yeah, what are your thoughts on general cord blood usage if you're pregnant?
Yeah, I mean, that partnership you have and that with Billion to One is very unique and very amazing. So, it's I mean, I'm very impressed that they've agreed to do that.
Yeah.
Their testing is very not new, but they're very different than some of the other companies, and so the testing they provide is different. And so they're able to do that. I'm not sure that any other of the companies would even um have that application. Um, so we advise our patients, we always give them the option and talk
Mhm.
about cord blood banking with them. Um, and we don't necessarily have a stance on it, but we make sure that they're informed and that they make
Yeah.
a personal decision. The patients have several options for cord blood banking. They could not bank anything and just discard it.
Mhm.
As you know, you can do a private banking, you can do public banking, and there's some also companies where there's like a combination or direct donor options. So we present the patients with the different options. We encourage them, if they're going to go with a private company, to do the research on the company, and their contracts
Mhm.
are very particular, and their fee structure and what the process is. If they ever need to use the blood, they should be well informed ahead of time, like what the policies and procedures and fees for obtaining the cord blood are, how long the company's been in business, has that company ever had their cord blood used,
Mhm.
and for a patient, or they just have only banked so far. So we really encourage them to get all the information they can to make sure they know kind of what they're getting into.
Right.
Um, Second, about hopefully not no one needs to use the cord blood bank. It's sort of like an insurance, biologic insurance,
Mhm.
and the likelihood of needing to use it is low, fortunately. Um, and it's been there are cases where particularly like private companies have used a cord blood banking for different kind of like blood disorders, like you
Mhm.
mentioned, that sickle cell disease or thalassemias,
Right.
different kinds of cancers. um and some like some immune diseases. So there are some actual applications. There's not a lot of necessarily literature out there on it because it's still kind of new and relatively new, and there's still and its use is not that common, fortunately. So I haven't had any of my personal patients had to actually use their cord blood yet. But of course, as we mentioned, we've had a lot of our patients collect the cord blood.
Mhm.
There's a lot of research being done on it, and we anticipate that it may have a lot of uses in the future.
Mhm.
So, if we're pressed, we explain to the patient it's kind of an insurance policy, and it may have even more applications in the
Right.
future. And a lot of parents want to do everything that they can um, for their children. And so if they really want to do everything, then technically this is something they should consider.
Yeah, that's awesome. Cool. Well, my last question around cord blood banking is we get a lot of sort of conspiracy theory type comments on our social media around what happens if they don't privately or publicly bank the umbilical cord and placenta. So I get a lot of questions around like thoughts around when the umbilical cord and placenta are thrown away. Like some people theorize that it's actually sold by doctors or anything like that. So what are your thoughts? Do doctors sell umbilical cords and
No,
placentas?
no, I don't sell any. And none of my colleagues that I know sell any.
Yes.
It literally goes in a bucket, and it goes on at least in the hospitals that I work at, it goes in a special secure location, and it gets discarded.
Right. So is it
They
incinerated?
I don't know what the lab does with it in terms of how they discard it. I mean that sounds plausible, but um, unless we request the placenta to be evaluated by the
Right.
pathologist, um, otherwise it just gets discarded.
Right.
There's no conspiracies going on that I know of.
Yeah. Okay, awesome. Well, I'd love to delve deeper into just high risk pregnancy, things around stillbirth, and kind of what your specialty revolves around. So, first of all, one of the really highly asked questions on Google, for instance, when you Google high risk pregnancy, is how is high risk pregnancy diagnosed and how is it further monitored throughout the pregnancy?
Absolutely. So, the term high risk pregnancy is very vague. And any kind of pregnancy that's just not routine
Mm-hmm.
is technically can be considered high risk.
Mm,
So anything that's not a normal, healthy pregnancy, and that can involve the mother or the fetus. Um, and so high risk pregnancy is a very generic, very vague, very widely used term.
right.
Um, I'm sure we'll get into a little more details about what kind of conditions we treat and things like that.
Yeah. What's the most common type of high risk pregnancy that you generally take a look at?
Oh, okay, yeah. I mean, like most common, but not necessarily most um, interesting because it's so common, would be like gestational diabetes
Mhm.
or high blood pressure pregnancy or preeclampsia.
Right.
Um, those are like early risk for like early delivery,
Mhm.
miscarriages, recurrent miscarriages. Those are probably the most common.
Right. And I know those that are pregnant above the age of 35 and twin pregnancies are also deemed high risk, right?
Sure, automatically. Like
Okay.
if you're over 35, Yes, all multiple gestations
Mm,
are considered high risk. Um, this issue of the age though, that's like at least in LA, it's very common
right.
to be over 35. You know, over 40 or 45. My oldest patient, I was 52.
Wow, and pregnant.
Yeah. And so 35 is like normal for us.
Yeah, it's interesting because I saw, Dr. Sterling, this OBGYN influencer, she posted a quick, like, TikTok talking about how there are actually some benefits to being pregnant above the age of 35, like, it's been correlated with longer lifespan for the mom.
W- Possibly, yeah, sure.
Yeah.
And I mean, it's just like, women are a lot, it's different these days,
Right.
and they're working, and I think women are taking over men in a lot of fields, actually.
Yeah,
And so they're just not having children as early as they used to. And
right.
so it's very common, especially in LA. I think if you go to other cities, sometimes it's not typical for them.
Mhm.
Um, Across the United States, and so they're automatically considered
Right,
um, high risk. And technically, based on the literature, those pregnancies are at higher risk for complications.
right,
Even though we've kind of gotten used to it here in Los Angeles.
right.
Um, if we see patients in their 20s, it's almost weird for us.
Yeah.
If someone's not over 35, it's weird for us.
Yeah. Okay. So if you're pregnant, you're below the age of 35, you're not having twins or triplets or anything like that, it's just a single baby, then what would be your number one tip to prevent high risk pregnancy?
Okay, so you bring up something important. All pregnancies are at risk for becoming
High risk.
high risk,
Mhm.
and it's something that a lot of people don't think about or don't
Right.
consider. So we consider all pregnancies at risk. First of all, we recommend pre-pregnancy counseling for everyone. Everyone, I think,
Mm.
should meet with their OBGYN before becoming pregnant, making sure, they don't have any medical conditions, making
Mhm.
sure they can get their blood tests, they can get their kidneys, liver, they can get like a full well woman exam, make sure their pap smear is up to date, um, make sure that they don't have any pre-diabetes, um, or any like underlying medical conditions they may not know of. So we recommend to have a preconception or well woman exam and be up to date
Mhm.
with your any like vaccines you need, etc. So to that's number one, and then being in good health and good nutrition, taking your starting your prenatal vitamins at least 3 months before, maybe even starting an exercise regimen if you can, if not just
Mm.
at least walking, but getting everything really healthy. It also improves your chances of becoming pregnant easier when you're ready.
Right.
Um, so I think just for anyone, whether they're consider themselves healthy and low risk, they can benefit from a pre-pregnancy consultation. There's even genetic carrier testing you can do before you become pregnant, instead of having to do it when you become pregnant and you're surprised that you and your partner may carry a genetic condition that you share. And just getting all of as much as pre-preg as much as things you can get done beforehand is probably the best um, a way to optimize your pregnancy and your pregnancy outcome.
Okay. Awesome. I know I put stillbirth as the next category, but I was thinking we could do that towards the end and cover other pregnancy complications, or
Sure.
do you feel, like, really passionately about it?
So our clinic is like a certified, one of the main things we work on is stillbirth.
Okay, awesome. Well, yeah, then
And some
let's
of
talk
your
about
other
it.
people that you interview may not
Right, right,
have
right.
that expertise, so it's
Okay.
good for you, yeah.
Yeah, yeah, I know Alyssa mentioned that that's your yeah, definitely domain. Um, okay, cool. Well,
Just stillbirth and all kinds of pregnancies, like recurrent miscarriages, or someone's
right.
baby died like soon
Mm,
after birth.
okay.
We deal with all help those patients get pregnant, like have a successful pregnancy.
Right. Okay. So I know that you're involved in a clinic that helps to specialize Or I know that you're involved in a clinic that specializes in helping parents that have previously had miscarriages or stillbirths. So I'm curious, what are the warning signs for a stillbirth, and how would you think about best methods of prevention?
Yeah, thank you. Absolutely. I'm glad we're talking about this topic. Actually, our clinic is a designated rainbow clinic, and we're the
What
um
does that mean?
yeah, so we're certified by an organization called Push for
Mm,
Pregnancy. And we follow very stringent protocols for monitoring women with previous pregnancy losses. So our
mm,
center is very passionate and focused on the prevention of stillbirth, and we do that for all patients, not just those that have had a pregnancy loss
mhm.
previously. So it's interesting. So there's only two rainbow clinics in the country.
Wow.
One in New York, and then the second is ours.
Oh, that's so awesome. I
The
didn't know that.
New York site was first. The concept started in the UK, so there's several in the UK, and the professor who started it there, and we had our own, um, stillbirth center, and then the we got introduced to the Push organization and the Rainbow Clinic, and then our center got designated as one. But it's interesting because
Mm,
we were already doing very similar protocols as they were,
yeah,
that we had developed ourselves, and then when we met them, we're like, oh, we're doing the same exact thing. So now we're the second um of two rainbow clinics in the United States. Stillbirth is very, very sad, not just
yeah,
obviously for for the women and the family and their family, but also even for providers. It's
right.
very
I feel like it's more
difficult.
common than people think.
Yeah, it's people don't really like to talk about it. It's
Yeah,
um I mean, overall it's rare, but it's definitely more common than people think. And a lot of um you asked for like warning signs. A lot of the prenatal care that you get is focused on the prevention of stillbirth without you
right.
really knowing it.
Mhm.
They like check for certain things at every visit, and part of that is to prevent stillbirth. Um, so yeah, we help women with any kind of, they could have like recurrent miscarriages or stillbirths, um, or even if they lost the baby early after birth.
Mhm.
And so, and honestly, the protocols that we developed, we now use it on even our routine pregnancies. Um, because every pregnancy is at risk, and we
Right.
don't believe that you should wait to have a stillbirth
Mm,
to get the care that a patient with a previous stillbirth would get.
right.
So I mean, you can come and join our center and be our patient. I would deliver you, and you could be a complete normal pregnancy. But we try to institute a lot of the monitoring that we do even in a normal pregnancy.
Mhm.
If you want to, it's usually that's why patients will come to us, even if they're healthy and they just
Yeah,
want the extra monitoring. Um, However, we also work with patients who don't want intervention,
yeah.
and I work with a lot of midwives that do home births, and we back them up and all that. So
Mm,
we cover we're open and we cover the gamut of everything. But in terms of stillbirth, um, sometimes there could be no warning sign, which is
yeah.
very scary.
Mm,
There's a lot of stories where people were at the doctor's office like the day before and everything was fine.
yeah.
Um, But some of the warning signs, and precautions for any pregnant woman, that we want to make sure that they're monitoring the baby's movements.
Mm. Like kid counting?
Yeah, so kid counting is like, and I'm glad you brought that up. It's like, and I want all the viewers to know. Typically, in kid counting, they tell you to like monitor the kicks once a day,
Right.
10 kicks over a 1 to 2 hour period. That's like literally the minimum.
Mhm.
And what a better way, what we really recommend now is, and we're trying to change it so women are always alert about the baby's movements. Every baby and every mom has their own perception of what's normal movements for that fetus.
Right.
And so the mom knows best, and they should get to know their baby's patterns, and most of them do. And some women will be like, "Oh, my baby moves all day long,"
Mhm.
or it particularly moves after lunch or after dinner or at night. So they really need to know the pattern of their baby's movements. And I kind of leave the kick. We teach everyone about kick counts, but it's almost like that's like the last resort. That's like the
Yeah.
minimum thing you should be aware of.
Mm.
Um, if for some reason some women like say that they're working all day long, they can't focus on the movements or they don't
Yeah.
notice it unless they do the kick counts. Um, so try to reserve it in like to like specific situations like that, rather than that being the standard.
Right.
So we recommend that everyone gets to know their baby's pattern of movements, and if there's any changes in the movements, that they seek care right away. They shouldn't make
Mhm.
any excuse that it's like too late in the pregnancy and there's no room.
Yeah.
A lot of women chalk it up to like there's less room now,
Yeah.
and I heard that when the later I get, there's less movement. So we
Mhm.
really try to discourage those kinds of thinking.
Yeah.
And so I think movements is like probably one of the number one things
Right.
that they should be aware of. Other things are of course like bleeding, or if they break their water,
Mhm.
if they have severe pain or contractions. We also recommend seeking care right away. Some providers will be like, if you broke your water or you're bleeding, you can take a shower and then come to the hospital. I don't subscribe. I'm like, you need to go right away
Yeah.
and get care right away. Um, and then another thing to be aware of, if you feel like your provider's brushing something off or they're not available, or you voiced your, concern, and they don't seem to be concerned, but there's something that's not right,
Mhm.
then you need to advocate for yourself, or you can just go to the hospital, and the nurses or physicians that are there that will be able to care for you.
Right.
Um, while it's best to go to your home hospital, you can go to any hospital, and they're obligated to take care of you. Um, and if there's something wrong and the movements are off, you don't need to call your doctor and get permission. There's so many times we'll get a call. Sometimes like a doctor will be out of town, so I'm covering, or
Yeah.
um sometimes I see patients in consultation, so their doctor's not available or they're in surgery or something. So they'll call and be like, their baby's not moving. What do I do? Like they should not be calling us
Right.
to begin. They should just already have been at the hospital by the. So we don't recommend. You don't need permissions. You can call on the way to the hospital and tell your doctor, or the hospital will call and tell your doctor. But um, you should get care right away is what we
Right.
recommend.
Okay. I'm curious because you mentioned stillbirth is such a sad thing or can be sad for providers as well. What drew you to the field?
Um, d- I do a lot of monitoring. What drew me to taking care of patients with stillbirth, or just high risk
Yeah, I
pregnancies
guess
in
just yeah,
general?
high risk pregnancies.
In general,
Yeah, and just the field of maternal fetal
yeah.
medicine.
So okay, I love talking on that. So, um, our field of medicine, I think, is one of the most special and most unique.
Yeah.
Most fields in medicine are caring for diseases,
Right.
and preventing, or like prolonging life or preventing death, so to speak, or like taking
Yeah.
care of your high blood pressure and your diabetes and your cholesterol and whatnot. Um, anyway, but on the flip side, like pregnancies and obstetrics is like you're dealing with new life,
Mhm.
and um, I think it's a very unique and rewarding specialty, and we always usually, if you're doing a good job, of course not everything's in the doctor's control or the patient's control, but if you're doing a good job, there's usually a good outcome.
Yeah.
And with high risk pregnancies, it's a very delicate, like balancing the mom and the fetus, and
Mhm.
getting them through a difficult pregnancy, and then we have a baby at the end and a healthy mom.
Mhm.
Um, rather than originally I was thinking of becoming like a cancer surgeon,
Mm. Yeah.
and on oncology surgeons and women's or gynecologic oncology surgeons are amazing.
Mhm.
They do They're some of the best surgeons in the hospital, and their surgical skills are absolutely amazing. But after the surgery, a lot of times the patients would get sick, and then or they'll be like in chemotherapy, and I was like, okay, you're doing all this amazing surgery, but then unfortunately, eventually, it's not a good outcome.
Yeah.
Of course, sometimes they prolong people's lives, and it's amazing. But concurrently, when you do an OBGYN residency, you have to do OB um and learning about like gynecology and the cancers and whatnot. But it was like every time we were in the OB service, we are having like all these like nice, like new life
Yeah.
outcomes. So, anyways,
I'm sure
high
you get a
risk.
lot of Christmas cards.
Yeah, like we have a whole wall in our office filled with cards. And so I being a cancer surgeon, you're dealing with high, kind of critical cases,
Yeah.
and so high risk pregnancies is very similar in that you're dealing with these very critical situations,
Mhm.
but at the end like the opposite is for new life.
Right.
So that's
That's
what,
interesting.
drew me into, and I also had an interest and passion. I learned about in utero fetal surgery,
Mm.
and it's like very cutting edge,
Yeah.
and you can operate on a fetus, and I thought
Mhm.
that was amazing. And we also specialize, it's maternal and fetal medicine, so we specialize in ultrasound,
Right.
and being able to do an advanced fetal ultrasound that we do, that high risk pregnancy specialists do, it takes a lot of hand skills. It's kind of like an operation in its own way. And maternal fetal medicine surgeons also do, like I said, they do deliveries, and they do uh, the fetal surgery. We do um, complicated C-sections. I could tell you so many stories. And we do also like cerclage procedures where the cervix opens. Like, I'd love to tell you about why I was awake all night.
Yeah, I mean, you can if you
Yeah,
want.
I mean, our field is amazing. So we do so many things. So like last night, I got a call. It was around like 8 o'clock. One of my colleagues, his patient just went to the office for a routine
Mhm.
visit, and she said something feels weird. She's having like some kind of vaginal pain, or just something didn't feel right to her. So
And
he
she's
checked.
pregnant.
She's pregnant. Yeah, sorry. She's about like 21 weeks pregnant.
Mm.
And so he checks, and her cervix is dilated, and the
Mm.
bag is like partially coming out.
Hmm.
So he calls me. He's like, "Oh my God, she's about to lose the pregnancy,"
Oh,
and she just felt something funny, but she really wasn't in pain or in labor. No bleeding, no signs. And if he had just brushed it off, it would have been missed.
right.
So she had something called cervical insufficiency, where your cervix just opens up
Hmm. What causes it?
without being in labor. We really don't know.
Okay.
It could be it could be some kind of genetic factors, or some kind of like
Right. Was she deemed high risk
we
before?
no.
Oh, okay.
I mean, no, for LA. Poor. So this is a very precious pregnancy. She's had 3 miscarriages, and then she
Mm.
finally had IVF,
Mm.
and now she's 21 weeks.
Right.
Goes to her routine visit, thinking everything's fine, and her cervix died, and she's about to lose the pregnancy. Um. So he called me, and I said, "Okay, send her to the hospital, and let's make sure she's stable, and we can give her the option of doing what's called a cerclage surgery, where we literally sew the cervix,
Hmm.
and put a stitch in it and close it up."
And then she would have to have a C-section.
Down the road, no, we remove. So first, we wanted her to make it through this procedure, but
Yeah.
we literally, I mean, like the pregnancy is coming out, and we're closing the cervix with a stitch. So
Okay.
we had to add her on to the OR schedule. Now it's like she gets to the hospital like at 9, 10 at night. There's like traumas, and there's brain surgeries going on. There was like an emergency in the ICU. So finally, it
Mm.
was our turn to go to the operating room at like. It's a very delicate surgery. I mean, you have two people's lives in your hands,
Mhm.
and there's we had to do a procedure called an amniocentesis,
Yeah.
where we took out water or the amniotic fluid out of the sac, and we send that for genetic and infection testing, but also just to reduce the pressure on the sac,
Mm.
so less of it's popping out
Right.
of the cervix. And then we kind of have to turn her a little bit partially upside down, and then push the bag of water back in.
Oh, wow.
And while we're doing that, put stitches in the cervix.
Mm.
And if you're it's a very delicate, if you first of all, the amniocentesis itself is a complicated, not complicated, but a high risk procedure that people are like freaking out about. So this one had to have, it's like 2 in the morning, she has to have all these procedures all of a sudden
Yeah.
done. um so we did our amniocentesis, we pushed the bag of water back in, and very carefully put in the cerclage stitch and close the cervix. And you have to be really careful not to break the bag of water. It's right,
Mhm.
like right there, sitting there. So so our fingers crossed. So the surgery went well. We
That's
weren't done till
awesome.
like 3:30 in the morning. It was really slow and careful.
Yeah.
And fingers crossed um, that the pregnancy stays
Mm.
in, and she's at risk for premature delivery the rest of the pregnancy, and she has to be very carefully monitored. Fortunately, these cerclages have always worked for me. I haven't had any pregnancy losses, but sometimes it's not up to, it's not, no matter how well you do the surgery,
Right.
she has a risk of losing a pregnancy. So it's still very delicate moving forward. But that's just an example of, um, our pregnancy is very, anything can happen anytime,
Yeah.
you know? So for me, you asked like if she was high risk to be in. For me, like those are all my patients have all these like recurrent miscarriages
Yeah.
and IVF, and they're older. But yeah, she's high risk, and this is a very precious pregnancy. So hopefully, we're able to save
Yeah, that's
her
awesome.
pregnancy and she continues. So that's just an example of something I wasn't even planning to do that. I was planning to go home early and sleep so I can come to the podcast today.
It's okay, it's
Yeah, so we do
important.
all kinds of yeah. Um, yes, we do all kinds of things. We do high risk pregnancy sessions, do complicated C sections.
Yeah.
Like I did with like an upside down C section instead of it being down here. When a couple weeks ago, our patient has like a big tumor, so her
Mm.
baby's
Oh, wow.
like up here, so her incision's like basically under her, like above her belly button. So it's like an
Yeah.
upside down C section.
Mm.
There's something called placenta accreta,
Yeah. Didn't Kim
where
Kardashian have
where,
that?
yeah, she had some spectrum of it, and luckily she was okay. But sometimes you have to have a hysterectomy, and there's a lot of bleeding involved, and so
Mhm.
some high risk pregnancy specialists specialize in that kind of surgery. We talked about the fetal surgery. We take care of women with cancer and pregnancy, and sometimes they have to get chemotherapy while they're pregnant.
Mm.
um Not so long ago, I had a patient with like leukemia in pregnancy, and we had to give her chemotherapy while she's pregnant, but then keep her pregnant as long as possible,
Yeah.
where it's not life threatening to her, but the baby's not born premature. We deal with women with like heart disease in pregnancy,
Mm.
of course, diabetes and high blood pressure, um, previous stillbirth. So we talk about previous complications in pregnancy. I mean, the list goes on.
Right.
And then we're not even touching on all like the fetal abnormalities that you can have, whether it's like brain,
Yeah.
heart, different organs. And we talked a little bit about the ultrasound. So, um, anyways, your question was why did I go into the field?
No, I feel like that's a
um,
good
but
explanation.
yeah, I mean, it's um, you're helping bring life into the world. We're not solely responsible. I believe in like some kind of higher power, God, and
Yeah.
and we're doing like all, I think all doctors, but we're doing literally like God's. I mean, like the surgery
Mhm.
last night is
Yeah.
literally, she would have lost a pregnancy if it had been in
Right.
24 to 48 hours from now.
Mm.
And I feel like we're, whatever this higher being is, or whatnot, we work very closely with them and kind of like our
Yeah.
messengers.
That's awesome.
And so it's a very special field. There's a lot of special things we do. and it's very rewarding and very unique. I could talk about it forever, but we'll run out of time if I keep going.
Yeah, well, just thinking about stillbirth in general, I was looking at like pregnant parents most frequently asked questions related to stillbirth, and one of them is what week is stillbirth most common, and what is the most common cause of stillbirth?
Okay, so there's like kind of three types of stillbirth. As you can say, like early stillbirth, which is like first of all, definition of stillbirth like varies depending on
Mm-hmm.
who you ask, but generally it's a pregnancy lost after 20 weeks.
Okay, and prior to
Um,
that, you call it a miscarriage.
yeah, technically, yeah.
Yeah.
Um, and then so there's like early stillbirths that are like from like 20 to 26 weeks, and then um like then the 27 to 36 weeks stillbirths, and then the late stillbirths, which are like 36 weeks and after. Everyone has different cutoffs, but that's like kind of roughly what people use. Unfortunately, the most common cause of stillbirth we don't know or is unexplained.
Mm,
Sometimes like anywhere
mm,
from 25 to 60% of stillbirths are unexplained.
wow.
Um, but
And how
we
common is stillbirth?
about it can be as high as like 5 out of 1,000 or
Mm.
6 out of 1,000. Um,
But miscarriage is like 1 in 4.
yeah, like even maybe 1 in 3. Yeah, a
Yeah,
lot of miscarriages people don't talk about too. By
right.
the way, or sometimes you can have a miscarriage so early that you think you're just like having your period late. So it's probably
Yeah.
way more common than we think. Yeah, I mean stillbirth is not as common um as miscarriage, but both are can be equally devastating to the
Mm,
mom and to the family. And so the most common cause is unexplained, and then we kind of divide it up into after that like issues with the mom, the placenta and umbilical cord, or the fetal issues.
mm,
So with the mom, if they have an underlying medical condition like diabetes or high blood pressure, especially if they're uncontrolled, if they have some kind of any kind of disease like we said, diabetes, high blood pressure,
yeah.
like if they're using drugs, um, if they have like underlying like a kidney disorder, any kind of medical condition you can think of, can increase your risk of stillbirth. Then there can be placenta issues. There can be problems with blood flow in the placenta,
Mm,
um, and issues with the umbilical cord, that we call it cord accidents. There can be issues with like the placenta separating or placenta abruption.
mm,
Um, Infections are another common cause. And then problems with a baby, whether it's like a birth defect, especially like heart defects sometimes, or genetic abnormalities.
right.
And then there's like trauma if you get in a car accident or something like that. Um, so those are some of the more typical causes, and but a lot of them are unexplained,
Mm,
and there could have been something wrong with the placenta probably in a lot of those cases. Um, and for some reason the baby didn't get enough oxygen, or
mhm.
the blood circulation was cut off to the baby.
Right. Yeah, my brother was actually had the umbilical cord wrapped around his neck, and so, yeah, it was kind of crazy because he was about to be born with cerebral palsy anyway because of that, but then they were able to fix the issue in time, but then he ended up getting into a near drowning accident, and then developing cerebral
Oh my
palsy
god.
that way a year later. So, yeah, and that's kind of why I founded the company. So, yeah, I'm familiar with the issues.
Wow, yeah, sorry to hear. It's just so crazy. That's what I'm saying, like you just never know.
Yeah,
And especially first time moms don't know
right.
that all. I think once you're pregnant you kind of realize like, oh wow, pregnancy can be
Yeah.
really can be something very high risk and dangerous.
Right. So is there a typical time frame that stillbirth normally happens, like week-wise?
Oh yeah, I mean a lot. Yeah, okay, so yeah, you asked that earlier. So um after the highest risk period would probably be like after 36 weeks.
Mhm.
But if you have an underlying medical condition or high risk pregnancy, I would say after 32 weeks.
Okay, interesting. And generally, what is the best treatment for stillbirth, after it happens?
Oh, after it happens. Yeah, so
Or before too?
I mean before we talked about like Okay, so both. Yeah,
Yeah.
to answer your question, kind of goes into both. Um, so there's obviously not like literally a treatment once the stillbirth happens, but you're
Mhm.
asking like how to kind of prevent it.
Yeah.
And so that's why now we do the extra monitoring on all of our patients. But
Mhm.
basically, first of all, we talk about from pre-pregnancy, you want to optimize your medical health, and then when you become
Yeah.
pregnant, you want to have, especially if you've had a previous stillbirth, you need to have, and depending on the cause, you want to have closer monitoring. So the first thing is to try to find the cause. Um, there's certain you can do certain blood tests to check for like blood clotting disorders you may
Mhm.
have, or underlying medical conditions that you may not have known you had. You can have your placenta checked, um, and a lot of hospitals have placenta pathologists, but some don't. So you can send your placenta to a placenta specialist, and there's one that we work with, who's well known in the area and at Yale, Dr. Kleinman. So a lot of people in the country send their placenta to him,
Oh, wow.
and that's like his expertise
Wow.
is looking at placentas and trying to figure out the cause, which helps a lot of women kind of get an understanding of what happened, because otherwise they would be considered unexplained
Right.
stillbirth. So finding a cause and then having close monitoring, having a very good relationship with your doctor, being able to like advocate for yourself. Um, Monitoring, it depends who you ask. Some people say it just means you should have 3 ultrasounds or 4 ultrasounds in your pregnancy, which in some communities that might just be standard. Or and you should get something called non-stress tests or antenatal testing
Mhm.
starting around like 32 to 34 weeks. Or you can go more extreme, which is what our like the rainbow clinics do. And I mean, in the first trimester we do weekly monitoring, and we're checking for all the kind of, especially if we haven't seen them before they got pregnant, then we're checking for all kinds of underlying medical disorders, making sure to help prevent them from having a miscarriage in that stage. And then in the second trimester, we see them at least every couple weeks,
Mhm.
whereas like typically you would see your doctor just once a month. Um, and then in the third trimester, we see them twice a week. And the very end, where it gets very high risk, sometimes we see them 3 times a week.
Mm.
And usually they get delivered early, at least a week before their due date, and depending on the circumstances, their prior pregnancy sometimes as much as like 2 or 3 weeks before their due date,
Right.
because that last part is we said earlier, is very high risk. So a lot of people think they're at the end, or they have like diabetes and are like, oh, we're at the end, and now I can like eat whatever I want because I'm delivering in 2 weeks.
Yeah.
But honestly, it's like that last few weeks are the most critical. The placenta is getting older. The
Mm.
baby's only alive because of the placenta,
Mhm.
and it's getting its oxygen and nutrients through the placenta, and so the placenta gets old at the end,
Mm.
and things can go wrong. You can get high blood pressure, preeclampsia at the end,
Right.
um, and you can get placental abruptions or separations of the placenta at the end.
Mhm.
So that last month is very important, and if you were diabetic, even if you weren't controlling your sugars well, you really want to control them and watch your blood pressures and the kick counts and the movements that we were
Mhm.
talking at. All of that at the very end is very important.
Okay, interesting. Yeah, I was reading that one of the most common questions that pregnant parents ask is which trimester is the fetus at greatest risk? So I know you mentioned like the last 2 weeks are really important, but is there a particular time where risk is highest?
Yeah, so after, I would say after 36 weeks, and then if you have an underlying issue like high blood pressure or diabetes, I would say after 32 weeks.
Okay.
The best time the In the first trimester, there's a miscarriage risk and the baby's being formed, so there's risks involved in the first trimester. The safest trimester, another way to answer your question is like the safest trimester is the second trimester,
Mm,
from like 14 to like 27, 28 weeks is probably the
okay.
safest time.
Okay, interesting. So yeah, I know we touched a bit on complications, and high blood pressure is definitely one really large pregnancy complication. So if you already have high blood pressure and then you get pregnant, then does high blood pressure impact the baby, and what kind of precautions should you take in those cases?
Yeah, so high blood pressure or preeclampsia is not just dangerous for the mom, it can be dangerous for the fetus too.
Yeah.
The blood pressures get too high, you can have placental abruption where the placenta separates, and like we said, the baby's only alive because of the placenta. So your blood
Mm-hmm.
pressures get really high. Um, Also, typically in preeclampsia, it's caused by an abnormal placenta and abnormal blood vessels in the placenta.
Hmm.
That end up as a result. You have an abnormal placenta, and it's not fully understood, but the placenta's blood vessels are abnormal, and so they don't. There can be some like um, there are abnormal changes in the placenta gives off. I'm just trying to make it as simple as possible, but some factors, abnormal factors that go into your circulation and cause you to
Hmm.
the mom's blood vessels to get tight and have high blood pressure. But um, underlying preeclampsia is an abnormal placenta, so the
Right.
baby is definitely at risk. There can be issues, like we said, besides placenta abruption, but there's also like a risk for fetal growth restriction, or the baby isn't growing well because the placenta isn't functioning well.
Restricted blood flow, so then
Hmm.
their growth is restricted.
Yes, they're growth restricted, or there's a placenta abruption risk. Um, and so and to the mom, there's like a lot of risks with high
Yeah.
blood pressure, and preeclampsia.
Okay, interesting. Does being pregnant make your blood pressure higher? That's another misconception that I
Yeah,
read.
no, it's a actually, your blood pressure gets lower.
Okay.
Your
Why?
blood vessels generally dilate to accommodate
Mm,
more blood in your. You have a lot more blood in your body, and so your blood vessels are a little bit more um in your veins and your blood vessels, and your circulation is a little bit more expands or
yeah.
like dilated, so to be able to handle the volume. Again, just trying to make it a simplest way to
Yeah.
understand it. And so actually, through a big portion of like the second and even like early third trimester, people's blood pressure actually goes down.
Mm. That's interesting because I've read that you're pumping up to 40% more blood volume through your body.
Yeah, yeah, even maybe more, 40 to like 60%. And
Yeah.
your veins and your circulation's a lot more dilated and
Mm,
expanded to take
right.
it. So your blood pressure is actually lower, especially in the beginning.
Okay. Interesting. Um,
So a lot of women, yeah, like if they have like pre-existing high blood pressure, chronic hypertension,
yeah.
their blood pressure can be really well controlled in the beginning, and then when we get closer to in the third later in the third trimester, it gets high and it becomes
Mm,
really high risk.
okay. Interesting. So moving back to sort of stillbirth and miscarriage, I know you talked about how the most common causes for stillbirth are unknown, but what are the most common causes for miscarriage? So loss earlier in the pregnancy.
Yeah, okay, that's a great question. So, um, and I'm sure a lot of people are wondering and think about this all day long because it can be very traumatic.
Yeah,
I mean, once you for some women, couples, and like once they see that pregnancy test, even if they're like a week pregnant
yeah,
or 2 weeks pregnant, they get very attached,
hmm,
and early miscarriages are very common, and it can be very kind of traumatic and hurtful
yeah.
and very sad. Um, and miscarriages, as we discussed, are very, very common. Unfortunately, likewise, the most common cause for miscarriages is unexplained.
Unknown. Mm,
Um, then the second most common are like if there's an underlying genetic abnormality with the pregnancy. It doesn't mean that it's something that was inherited.
yeah.
We always remind the parents that it's not something that was necessarily inherited through, uh, either parent um, you know, or through the family, or if you're doing IVF, they're like, we whether they use their own egg or donor's
Hmm.
egg or donor sperm, they like genetically test it. But sometimes things can go wrong. I mean, you're starting with a little ball of cells and forming a human, and so
Hmm.
along the way there can be something can go wrong in the in the genetically in the DNA, and so um, usually we like to think that genetic abnormalities are um, like the second most
Yeah.
after unexplained. And then we get into like the things that we discussed before. If there's like an underlying medical disorder or medication use or substance abuse or some
Mm.
kind of trauma, some kind like the people have like autoimmune diseases or blood
Mhm.
clotting disorder diseases that they don't know about, um or they had like a thyroid issue or a diabetes issue they weren't aware of.
Yeah.
But a lot of times we just don't know. We try to remind everyone it's not their fault. So the most important is that uh, for people to understand it's not their fault.
Yeah.
Um,
Yeah,
because
what
even if like there is a cause, first of all, a lot of the unexplained ones, like people start thinking like, oh, did I like, was it because I exercised or like bent
mm,
over? Was it because I picked that thing up, or is it because I got in an argument?
yeah.
When people get in stress. You're right. A lot of newly pregnant women are stressed or very emotional.
Yeah.
I mean that's like a whole nother topic, and they and then their partner can be very stressed too in the beginning. And so it's not uncommon that, or like someone's one or the other's like moody and they'll get in a
Yeah.
fight, and then they'll try to like, was it because we got in a fight, or was it because I had coffee or some, I don't know. They'll come up with all kinds of things to try to explain it,
Right.
and we just try to remind them that like it's none of those things.
Yeah. Yeah, what do you typically say to parents after they've had a miscarriage or stillbirth in the past? And also, does having a past miscarriage or stillbirth make it more likely that you'll have one in the future?
Anytime you have something, it makes it more likely to have in the future, but
Mm.
most women go on to have a normal pregnancy. And so as soon as, I mean, like, first of all, it's very hard to break the news,
Yeah.
and that took like years to figure out how to tell someone.
Yeah.
Um, but so once we like break the news to them, then I quickly go into, because I know that they're like starting to think of all these things they did
Yeah.
that caused it, or they start blaming each other, or they start thinking of like genetic things, and we like right away start. And I'm sure they want to be alone, but they also need to be reminded, and so we usually right away, if they give us the opportunity, try to explain that it's very common, what the possible causes are, and that we discuss, and then we remind them that it's not any of the things that's probably going through their mind right now as
Right.
we're like talking. um, and then they start asking, oh, so it wasn't because I actually, they've already like within seconds started thinking of these things, so I try to
Mm.
preempt, or like preempt it right away.
Yeah.
um So we try to give them a lot of reassurance and explain to them that it's not their fault, and talk about the different possible causes, even the genetic ones. We said they're not the majority of the time are not at all inherited, and so
Mm.
we try to remind them that most women will go on to have a normal pregnancy, but unfortunately, like no matter what you tell them, it's a very sad moment.
Right.
And the excitement, especially for anyone, not, I was gonna say for first time, but for anyone, like that excitement, they get very attached
Mhm.
to their pregnancy very quickly, and so it's
Yeah.
a huge like letdown. Even though they know, and a lot of women know that miscarriages are common, and
Yeah.
it's still very difficult.
Yeah. Do you have any like patient stories that you typically point to that are really optimistic or help inspire parents that have many
I mean,
miscarriages?
yeah, we just try to remind, like literally, I have to get bad news like every day,
Mhm.
and I just try to explain to them like we this morning we told someone they had a we try to just tell them it's very
Yeah.
common. It's especially hard for the ones that have like recurrent miscarriages, but not all of them, but a lot of them end up eventually having a baby, and so
Yeah.
we try to explain to them how common it is and how many times we saw it that day already or that week.
Right. Yeah, like, I know that Chrissy Teigen is kind of a controversial figure, but I feel like her family story is so interesting in that, like, even they had, like, the concurrent surrogacy and all these things, so, yeah, do you happen to know why her stillbirth happened?
So if you're talking the one that was like in the media,
Yeah.
or and she talked about a lot,
Mhm.
um, I actually was one of her physicians for that pregnancy,
Oh.
and she talks about it. But I mean, basically, without getting into, I don't know, I don't remember what she said or didn't say, but um, she ended up explaining actually that she had, recently with there's all these like new laws in different states about like pregnancy terminations and
Mhm.
stuff. Um, Technically, she explained that she had to terminate her pregnancy because she was having a lot of bleeding that was almost kind of
Right.
becoming life threatening for her, and so, um, but is all under the category of like pregnancy loss, and so usually, typically, bleeding is caused by the placenta and the
Mhm.
placenta having like a separation or bleeding, and I mean, there's just so much you can bleed before it becomes unsafe.
Right. Awesome. Well, yeah, I wanted to also chat about high risk OB care. Like, I know the field of high risk OB care and being in MFM is actually pretty like frequently searched term. Just because I think, like you said, a lot of parents I think spend a lot of time thinking about how they can reduce the chances of being high risk. So, is being a high risk OB the same as being an MFM, and when should parents seek the support of either?
Yeah, so um, it's a great question. Originally, our field, our specialty was called perinatology.
Mhm.
Um, or yeah, perinatologist. So some older folks they'll call us perinatologists. Um, and then it's also known as maternal and fetal medicine, and that's what it's like term now, and that's how we're like board certified is maternal and fetal medicine specialists. That's what our training is called. And then we're also called high risk pregnancy specialists.
Mm.
So we
So
go
it's
by
kind
all
of one
three.
and the same.
Yeah, they're all the same. Perinatology, maternal fetal medicine or MFM, and high risk pregnancy.
Mhm.
Those are all the same. Um, you there are not that many high risk pregnancy specialists in the country. Um, there is only about, we think, from our based on our like board certification or society, maybe about like 2,000
Mm.
or maybe even less practicing actively in the country.
Do you think that's enough?
Um, so each like high risk, I don't think it's enough, no. And each high risk pregnancy doctor serves um a large community or a large
Mhm.
community of obstetricians. So it depends on what pregnancy what model is in your community. We talked
Mm.
about how in some communities there's a high risk pregnancy doctor that just does consultations and works with an obstetrician.
Mhm.
So let's put it in terms of the patient, or because that's our viewer. So you're pregnant and you have your OB, and that's who's going to see you and do your blood tests and answer your questions and deliver you. And then they will, most of the time, again depending on where you are, if there's a high risk pregnancy specialist available or your obstetrician agrees to work with one, which they should, they'll send you for your like ultrasound.
Mhm.
And typically you'll get anywhere from as little as like 3 ultrasounds during the pregnancy, 2 or 3 pregnant ultrasounds with your high risk pregnancy doctor.
Hmm.
And then that way you've established a relationship with them. In case you become high risk, then they've done your ultrasound and they'll intervene and help your obstetrician.
Yeah.
Then there are high risk pregnancy specialists who do total OB and MFM care, where you take care of the OB part and the high risk part. and you take care of both, normal pregnancies and abnormal pregnancies, because any of the normal pregnancies can become high risk, and you definitely take care of, obviously, the high risk pregnancies. So an obstetrician in the first model, an obstetrician in conjunction with a high risk pregnancy doctor, um, many of them can take care of a high risk pregnancy and do a delivery, but they will be leaning on the high risk pregnancy specialist to tell them what to do, or help with the monitoring and when to deliver, and um, consult with them. So your high risk obstetrician in that situation may be like kind of really managing your whole pregnancy, but then your OB does your delivery
Mm,
because that's who your primary doctor was to begin with, even though you became high risk. So that's like one model. The second one was where the high risk doctor does everything, whether you're normal to begin with or high risk. And the high risk doctor does all your prenatal care, all your ultrasounds, and your delivery.
mm,
Um, and so there can be either of those two situations. And so some of the women who are high, they know they're high risk, they may seek, if there's a high risk OB doctor does deliveries, to just be with them the whole time. And that's probably ideal for those very high risk patients, but that's not always available. In some cities, you will just have, like, your high risk doctors never do deliveries, so they'll just be
right.
consult consult only. So, or you might then travel to like a university base kind of situation where those high risk doctors they do deliveries, or they work with their OBs in the hospital or university. And then there's also some rural communities where there is no high risk
Mhm.
doctor anywhere
Right.
in the city or even part of the state or
Yeah.
region. And so now a lot of high risk doctors are available by telemedicine.
Mm. Yeah, I've
Um
been reading more and more about maternal deserts increasing in the US.
yeah, so like there's a whole there are several now companies or organizations, or my colleagues, they do telemedicine,
Mhm.
and they do read the ultrasounds remotely, and they'll also, with like a camera at the bedside, see patients in a hospital in a different state,
Mm.
because there's just not any high risk doctor around physically
Right.
there. And there never was, and some of those hospitals, like the OBs, were for years just on their own, and now so they have the high risk doctors present by telemedicine. um with the increasing age, or whether it's obesity or whatever population changes, we're seeing more and more high risk pregnancies.
Mm. So high
And
risk
so
pregnancies are
are
increasing
increasing,
nationally.
yeah. And the role of the high risk doctor is ever increasing.
Mm. Interesting.
We believe, then in terms of the ultrasound, like, so if you're just a normal pregnancy, you have to get at least like 2 or 3 ultrasounds with
Mm.
the during the pregnancy. We did the bare minimum. Our Society for High Risk Doctors, and Society for Maternal Fetal Medicine, we really push and recommend that your your detailed ultrasounds are done by a maternal fetal medicine specialist.
Mm.
Some OBs do their own ultrasound, or they're skilled in it, or they have like sonographers who are certified in it, or there's just not a high risk doctor available. But to the extent, if they are available, you should get your ultrasound with a high risk pregnancy specialist at minimum, and have that care kind of established with them.
Yeah.
Um, and then personally, I do a little bit of both. We do the consult only um, care for as a perinatologist, but I also do a total OB and high risk pregnancies care, and do my own deliveries.
Mm.
So I do both. It's kind of split.
Cool. I've chatted with parents who talk. Yeah, go
Oh, I
ahead.
just wanted to say, and some people think it's like weird. Why would you do there's a lot of people become high risk pregnancies because they don't want to even do they just want to be like consultated. But when you take care of, like, there was a time where I'm just doing consult only, and it's not
Mhm.
as the high risk doctor like takes care of all these like complicated things, and they're not even at the birth, which is like
Yeah.
really sad.
Yeah,
So,
that makes sense.
yeah, so I enjoyed, like, doing the deliveries,
Yeah.
and so I started doing like, taking on the whole
Right,
patient for
right.
myself, but, anyway, so I kinda split but I worked with my or OB colleagues for many years, so anyways, I think, yes, OBs can take care of some high-risk pregnancies, usually in
Mhm.
conjunction with
Okay,
a high-risk pregnancy
cool.
specialist.
Yeah, I've chatted with parents who talked about, like, I feel like a lot of parents are just generally concerned about decreasing intervention during birth. Especially if they're a high risk pregnancy or anything like that. Yeah, I feel like people are just worried about interventions leading to further complications. So, if you're currently pregnant, what kind of methods should you take to reduce intervention? And also, what are your thoughts in general on midwifery versus OB assisted deliveries when it comes to interventions?
Yeah, that's like it's a big topic.
Yeah.
I personally, so I mean, it's really we believe. Okay, so there's something called like shared patient decision making, and so
Mhm.
if a patient doesn't want, I don't even want like to say that it's not that they don't want intervention. I think that some patients, I work with a lot of midwives,
Yeah.
and I don't think we should label them. Not that we were like talking about it, even like I mean, like before I walked in here, I would probably label them the same way, like they want least intervention.
Mhm.
But it's interesting after like all we've talked about, and then when you asked me that, I'm just thinking like we shouldn't. Those patients don't need to be like labeled
Right.
as. And I didn't think of this before, but I'm just thinking
Yeah. No, that's fair. That's a fair point.
it's not that they don't want intervention or they're bad
Mhm.
patients or they're
Yeah.
crazy. Like you'll hear like, why would they want to deliver at home, or why would they not want to have intervention? I mean, that's their personal decision,
Yeah.
and sometimes they've had like medical trauma,
Right.
um, or they had a bad experience in the hospital and they're traumatized, and so they want to deliver at birth, or they had like a family member pass away in the hospital and they want to deliver at, I mean, it could be a million reasons, or they just want to be comfortable at home, or they believe pregnancies, one thing, it's not they don't believe in pregnancy as being a disease. They don't even call their patients, they call them their clients.
Yeah.
So, they call their like a lot of midwives they call their patients their client, and I asked them like when I first started, I'm like, why are you like what is this about client? They're like, Steve, pregnancy is not a disease. Like,
Yeah.
why are you calling them a patient?
Uh-huh.
It's not like they have a medical disease. They're pregnant. And so some people believe want a natural, kind of as natural as possible, pregnancy, and to have the least medical intervention just because they want to be natural,
Mhm.
or they've had medical trauma, or they just, um like we said, they think pregnancy is not a disease. And I actually had a patient the other night who's an ICU nurse
Mhm.
who sees very sick patients all day long in the hospital
Yeah.
that are very critical and like on the verge of dying, and she's electing to do a home birth with a midwife. And so like I'm like, okay, this is very interesting. You're an ICU nurse, but you want to do a home birth. Like, can you explain to me, in my head? But she actually ended up telling me herself, because she was like talking about her job and what she
Mhm.
does. And she's like, "Oh, you're probably like wondering why I'm like this like ICU nurse, but I'm delivering at home." It's like such a stark
Yeah.
difference. And she just said, "You know what? I'm in the hospital all day long and seeing people dying. I want to like have my baby in peace at home. I don't want to be in the hospital where
Yeah.
I work having my baby."
Yeah. No, I've actually thought about that myself because my brother growing up, like I mentioned, he had cerebral palsy. So we were always kind of in and out of the hospital because his was pretty severe. And then, yeah, even like one of my old boyfriends had a pretty severe ulcerative colitis. So I was like constantly in the hospital then. And being in hospital environments gave me anxiety. Like my dad's an anesthesiologist. So he used to take me when I was younger with him to work sometimes. And I would just, like, sit in the waiting room basically while he was checking in on client or on patients. And it always gave me anxiety to be there. So when this doula I was once speaking with was talking about how like birth should basically be a really serene environment so that it can move really smoothly. I was like, I don't know how I can make it a serene environment for myself if I'm in a hospital and being in hospital settings give me anxiety.
Right. I mean, like, and if especially if you're like trying to be at a good hospital and they're like, it's busy,
Yeah.
and it's loud and there's like IVs and it's like very medical,
Mhm.
so I mean, it's just really up to the patient because some of them want to have least intervention and want to have like a more natural kind of experience and they don't believe pregnancy is a disease. And then there's some patients who are nervous about every little thing and want to come to the doctor three
Yeah.
times a week and they don't even want a labor, they just want a C-section. I mean, so we
Yeah.
have like the whole range. And so I work with a lot of midwives in the beginning. A lot of doctors have an issue with midwives or doulas, and they had to, I had to really work with them closely and started to gain their trust.
Mm.
And I saw that they're very knowledgeable, they know what they're doing, um, and especially if depending on their experience level, some of them are very, very good.
Yeah.
And they know like when it's time, when someone risks out and they shouldn't deliver them at home. They
Mhm.
know when to move to the hospital. Um, and so it took a little bit of, I mean, I just remember like my first time working with a midwife, I was like, it was not working. And then, but we stuck together and like,
Mhm.
she literally like explained to me what they do and she trained me and I started getting used to the words they use. And at first I thought they were crazy. And then I've like, over time, I'm like, got very used to working with them and completely now understand their model of
Yeah.
care and understand why those patients want, for whatever their reason is. They all have a reason.
Yeah.
They want midwifery care, and or a home birth. And there are some midwives. There's a lot of midwives that deliver at the hospital too.
Mhm.
Um, so there's midwives that like some hospitals, like Kaiser system, for example, like all their low risk deliveries are done by midwives.
Yeah, and they do it in the hospital
Yeah, they
with
do
a
it in the
midwife.
hospital.
Yeah.
Then there's like, I worked for a short period of time at UC San Francisco, which is a very like one of the top hospitals
Yeah.
in the world, and especially for high risk pregnancies.
Mhm.
And their midwives there deliver the high risk. Like if they're getting a vaginal delivery, the midwives deliver them, and they're high risk.
Yeah.
I mean, they could have been in the hospital for months and like have heart disease and the midwife is delivering them. And then if they need a
Right.
C-section, then the doctor who's like on call will come to do the C-section if they happen to need one. But otherwise the midwife is doing the delivery. So there's all kinds of midwives, and if you have a good one who's well experienced, they know generally they know what's safe to deliver at home and not.
Yeah.
And then I because I'm a high risk pregnancy specialist and I worked for a little bit of time as what's called a laborist. We just deliver like random people who come in.
Mhm.
I'm able to back up a lot of midwives if they want to transfer care. So if something happens and the patient risks out of delivering at home, or they might need a C-section because the baby's breech.
Yeah.
And they've tried to turn it and they've tried a million things and it won't turn, then I'll do the C-section. So I have a very now close relationship and understanding with the midwives, which is uh, not common for OBs. There's always this like, unfortunately, they don't always get along,
Yeah.
or they have like complete opposite perspectives of each other.
Right.
But because I was at UCSF, because even at my current hospitals here in LA, they have midwives. Because
Mhm.
in my private practice, we worked. The midwives kind of trained me and explained to me what they do. I'm very now open to it all, and so we let the
That's
patients
awesome.
decide. And if they need, I don't do home births. I don't even know how midwives, like at the hospital, I have so much help. There's like a million nurses, and sometimes we have residents, and
Yeah.
like midwives do it like they have like they're either alone or like with an assistant. I've promised that I've been wanting to go to one of their home births and see it because I don't know how they do everything that we do with all the help in the hospital. They just do it all alone
Yeah.
at home. So actually, I'm very impressed by midwives in that regard.
Yeah.
And so yeah, we love working with them, and I love backing them up, and it's basically we let the patients decide, and it's what's called now we call like shared patient decision making.
Okay. Awesome. Cool. Well, thinking more about high risk OB care, who is the most at risk for problems during pregnancy?
Um, Everyone, but no, I mean obviously, like if you like, if you start out with an underlying medical condition,
Yeah.
um, or that's not well. I mean, you can still have that's not well controlled. I'll say because you can have an pre-existing hypertension or diabetes, but if you control it well before you become pregnant, you can have a great.
Right.
It'd be high risk, but you can have a great pregnancy. So I think
Right.
who is at highest risk is like someone who's not taking care of their health or their uncontrolled um, underlying condition, or if they develop a complication during pregnancy. Um, and then, as much as I want to deny it because we're here in LA, like older age, I guess,
Right.
like, especially if you're over like 40 or 45, it gets riskier. And those patients definitely get an extensive like workup beforehand and clearance.
Mm.
And we make sure their heart, for example, is functioning well
Hmm.
before they become pregnant. Um, but a lot of those women do go on to do great. Like I said, like, we have a 52-year-old
Yeah, that's
patient who's
awesome.
pregnant. So yeah, I wouldn't even necessarily I mean, like, yeah, I want to deny it because I don't think age should be like because it's so common here, we're used to it, but it is one of the risk factors. But
Yeah.
probably someone who's not healthy and
Right.
who has uncontrolled conditions, right, at highest risk.
Okay. What are three signs, or if you're currently pregnant, what are three signs that you should not ignore during pregnancy?
Okay, yeah. Bleeding, um, changes in the baby's movements,
Mm.
and then I would say like if you're just not feeling something, if you just feel something's off.
Okay.
We always say the mother knows best, whether
Yeah.
it's like they just feel a pain or the baby's not moving or they feel nauseous or something's just not right. We usually tell them that their instincts are probably correct.
Okay. I have two more questions, and it's around premature delivery, which we haven't touched on too much. But what are the warning signs for premature labor, and what are generally the main problems for premature babies?
So like everything else in pregnancy, sometimes there could be no warning signs and suddenly you have a preterm birth.
Yeah.
Um, but if there are going to be warning signs, sometimes you can have like contractions.
Mm.
And you're premature and you shouldn't be having contractions. So bleeding contractions, obviously, if you like um break your water or you're starting to have high blood pressures, there's something off with the baby's growth.
Mhm.
Um, because premature births, there can be like what we call like spontaneous premature births, where you just go into labor early.
Mhm.
Um, and so you might have those like clinical symptoms, or an ultrasound, your cervix is getting, you have a short cervix.
Mm.
And then there are some medically indicated preterm births, like for high blood pressure, for example, or a fetal condition or maternal condition necessitates us to, or the baby's not growing well and we have to deliver early, or a condition called like cholestasis of pregnancy, um, or oftentimes like multiple gestations. So there's like medically indicated, and then there's like the spontaneous ones.
Mm.
So for the spontaneous ones, it would just be basically like mainly those symptoms.
Okay.
With the risks of prematurity, it really depends on the gestational age. As the baby gets older, obviously the risks are lower.
Yeah.
But some of the common risks, like like some of the more common ones, are respiratory issues or breathing
Mm.
issues or respiratory distress syndrome. Um, and so like breathing and lung issues. So a lot of premature babies get intubated. Feeding problems with like feeding, um, and weight gain. You can have intestine disease, or issues like blood flow to the intestines,
Mhm.
or um, you can have brain bleeds. Depending on the earlier the birth, the more high risk. But so bleeding in the brain, vision problems, hearing problems,
Mm.
disabilities, and just like the further you get out, especially like after 28 weeks or 32 weeks or 34 weeks, the risks of prematurity are lower. And so
Right.
preterm birth is considered before 37 weeks.
Okay, awesome. And then a quick bonus question I was thinking about is I know you chat a lot about ultrasounds, especially since you're MFM. And I read a study that higher quantities of ultrasounds are correlated with being left handed. Do you know why that correlation might
No, I
be?
have no, I have no idea. And honestly, but I'm glad you brought the question. I guess this topic. No, I don't. I've never heard. Actually, I've never even heard of that.
Okay. Is having
But
more ultrasounds
yeah,
dangerous?
I was gonna say no. So our machines now are regulated. Early on when ultrasound first came out,
Mm-hmm.
what they call like the frequency, or like like the frequency of the ultrasound were much higher. But now, um, especially if your center is accredited, the machines, um, and you have like fetal ultrasound machines, they're usually calibrated for fetuses, and if you follow, there's like very specific settings you should have on your machine. And it's very low frequency. So like there are uses of ultrasounds that even for like certain medical conditions, or like
Mm-hmm.
tumors and things like shrinking tumors, like the fetal ultrasounds are nowhere near those. And so they're yeah, we don't know of anything being unsafe about ultrasounds or the frequency of getting
Right.
ultrasounds. Their ultrasound, if it is like a high enough frequency and you put it on long enough on a tissue, it could cause um like heating of the tissue. But I mean, it would take weeks. You would just have
Yeah.
like sit there for the ultrasound for weeks, like just on you, or
Yeah.
months in theory, if that would even happen. But no one sits there with an ultrasound like glued to them. So yeah, we
Yeah.
don't think. I mean, there's nothing um unsafe
Okay.
that we know of.
Okay, cool. Well, that's all the questions that I have, but do you have any sort of parting words to parents that are high risk or maybe have had losses in the past?
I mean, just everything we kind of talked about.
Yeah.
Just so to be try to be healthy before
Mhm.
you get pregnant, and if you do have a medical condition, try to get it under control before you get pregnant. You can meet your high risk pregnancy doctor ahead of time.
Mm.
Sometimes I meet patients like a year or two before they become pregnant.
Mm.
Okay, and
Interesting.
we sit down and we plan their entire pregnancy two
Yeah.
years ahead of time, and how frequently they're gonna see me, and how many ultrasounds they're gonna get, and what medications we're gonna use, and
Right.
what delivery plan. And we have a plan already in place. So literally, you can plan your pregnancy way like before you're pregnant.
Yeah.
Um, and so I just think like just like optimizing your health
Mhm.
before you become pregnant, advocating for yourself, and if something's wrong, to speak up. Um, and um, and in terms of like picking your doctor, you can make sure you're a good fit. You can likewise, before you become pregnant, interview different doctors and different offices and styles, and get to know them. And then with um, we talked about all the things you can do for like preventing stillbirth for those
Mhm.
women who've had stillbirths or recurrent pregnancy losses. You would probably want to see a high risk pregnancy specialist for your future pregnancies. Get the extra monitoring. Have someone that understands and is willing to work with you and listen to you. And um, but also at the end, not to get too stressed about it. I mean, at the end, um, The idea of being pregnant is to have a child, and that's
Yeah.
supposed to enrich your life and be a blessing. And by the way, I mean, like we didn't even get. I don't. I'm sure you don't. I don't think you talk about this, but having it. There's also the other side of it. Is also not easy.
Mm.
Raising a
Yeah.
child. So
Do you have kids?
so yeah, I have kids. So, people joke around like it's always better in than out because that's a whole like once it's out, there's a lot of
Yeah.
other stress you have and new worries about like what formula or about
Mhm.
breastfeeding and sleeping and
Yeah.
schools and for the rest of your life, really.
That's cool.
But yeah, so even if you're high risk, just have a good doctor and advocate for yourself and be
Yeah.
prepared ahead of time um and try to enjoy it too if you can,
Right.
because pregnancy is supposed to be also an enjoyable time.
Okay, awesome. If people want to reach you, how can they best find you, and especially your clinic since it's one of two rainbow clinics in the US?
Yeah, so the easiest, we're here in Los Angeles, and my office is in West Hollywood at the Cedars-Sinai Medical Office Towers, which is just adjacent to the hospital. But the best way to probably reach us is through Instagram,
Cool.
because a lot of contact information and
Awesome.
links like Linktree and all that stuff is there. So it's at Dr. Steve Rad.
Cool.
So it's very easy at Dr. Steve Rad. This is
Cool.
probably the easiest
And
way to find us.
what's the name of your clinic?
So it's a center for maternal fetal health and high risk pregnancies and also the Los Angeles Fetal Maternal Care Center.
Okay, awesome.
Yeah.
Cool. Well, thank you so much for being here today. I'm really grateful, and this was super informative for me too.
Thank you. Yeah, I love talking about what I do
Yeah.
and thank you for having me and I can't wait to see it live.
Yeah.
And thank you very much. I really
Okay.
enjoyed it.
Yeah,
Yeah.
awesome.